You all set? All right. Thank you. Travis, appreciate it. So I have to stand where the X is. All right. This is interesting. Well, good morning, everybody. How y'all doing? Who have been here at Gerald Champion before? Anybody? Nope. Okay. Well, welcome. I'll take about 50 minutes or so to kind of introduce you to the hospital. I think it's important when you get started here, you kind of have a sense of what we're up to and where we came from and where we're going. I'm Jim Heckert. I've been the administrator here now for a little over 12 years. Came from Indiana in the southern part of the state, and before that I was in the Army and going around doing my thing in healthcare. Have 3 sons, all employed, and we have 10 grandchildren. So they're doing good. And unfortunately, we can't see them much right now. That's a drag, is one of the outcomes of what's going on. But we've been blessed. So at one of the jobs I had, I was stationed in El Paso at Fort Bliss, where I was the chief of clinical support at the hospital when it was a trauma center in those days and in the mid-'80s. And you could go to Juarez and have a wonderful meal. Juarez used to be a really cool place to go. I would not recommend it now. Someday, hopefully, that'll return, because it was a great place to go at the time and really helped we sort of fell in love with this region. And so when we were looking to go to another chapter of our life, my wife said, well, let's just look in New Mexico and Texas. And so we did, and here we are. And love it here. I spent years in Washington, D.C., commuting an hour and a half one way. Don't miss that for a minute. And so we still go back periodically, and I last about 3 days, and then I want to get back to Alamogordo. You know, there's times in your life where that stuff's nice. I particularly like here, because this is still a small community, not like I can remember Las Cruces when it was 50,000 people, much more quaint than what it is right now, because it's basically a bedroom community of El Paso. And so our town, because it's surrounded by governmental land, will grow, but it won't have urban sprawl like you're seeing out there. And frankly, I kind of like that. So let's just talk about the hospital a little bit. Interesting hospital. In New Mexico, which is the 5th largest state, which I always forget about, there's 2 million people. 1 million of it in Albuquerque and Santa Fe. And the rest are scattered to the winds. And so with all the healthcare reform you hear being discussed about, it's discussed from an urban perspective, not a rural perspective. And we have different challenges because of the way our populations are spread. So it's just something we got to think about. Of the 44 hospitals in New Mexico, there are 2 that are independent. San Juan up in Farmington in the northwest corner of the state, and us. And so everything you see that we do here and we're accomplishing, there is no lifeline. We're it. We make a mistake, we own the mistake. We suffer from the mistake. If we win, we all win together. One of the board's philosophies is simply, as we succeed, so does everybody. And we make it a point to do that, and you'll see that in your time here. We've had tough times in the time I've been here, and we've shared those too. That's just part of being a family and the things we do here at the hospital. So Gerald Champion in the early days, in the 40s, was an established family, the Champion family within this region. And Alamogordo then was a whopping city of 3,500 people. And you know, our roots come from the railroad, right? I mean, as the railroad was going west, and you see the big water tower, that's kind of how we got started. And so Gerald Champion felt like we should have a hospital here and not a house on Indiana Avenue that was a clinic, a railroad clinic, because we stabilized people and basically sent them off to Cruces, or probably more like El Paso in those days. So he set about trying to raise $200,000, and he could only raise $150,000. So he went to the county commissioners and asked them would they loan him the $50,000 to get a hospital going in this town. And Charisse? What do you think they said? Probably not. That's not what they said. No. They said no. But what they countered with is, give us the 150, we'll build it for you and charge you $1 a year lease. And that's what we did. For 40 years, the hospital existed right over here across from Albertsons, where the Ontario Federal Credit Union is, in that 1 square block, and grew from a 1-story facility to a 3-story facility. And as it expanded, the county absorbed the cost of the expansion. We didn't. And we're not a county hospital. We're an independent hospital. But pretty smart on the leadership in those days, because they know that in a rural setting, hospitals are typically your #1 employer and typically have a better average salary, which is our case here. And so off we got started. And so for 40 years, it was a great relationship. But things change. Healthcare reform, as you all know, with Obamacare and all that, it's really not healthcare reform, it's financial reform. And there's been lots of different iterations of that over the years. Well, in the mid-'80s, there was a thing called DRGs, diagnostic related groups. And if you work in the hospital, that's how we code our inpatient work to get paid. And so we have a staff member here that's been here 46 years. And she remembers the day when we billed $1, we got paid $1. Those days are long over. Now we bill $1, we get paid 30 cents, and part of that is the DRG and the insurance companies and the discounting and all that sort of thing. So it really changed the flow of work and how we got paid, and the hospital was suffering in the mid-'80s. They weren't sure how they were going to make it work. So they brought a consultant in, and the first thing they said was, we're blown away that you don't have a mortgage. No hospital, every hospital has a mortgage, but you don't. That's incredible. There's only one other problem. Your hospital's 40 years old and it's bedraggled looking, and you need to replace it. And you've got $70 million leaving the county to get care in Cruces or El Paso. So you need to do something differently. At the same time, the county came along and said, while we were soul searching and trying to figure out how we're going to make it, we can't do this anymore. The county has more demands than we can meet. You're on your own. Well, that's at a time when we weren't sure we could even make it. So stress was a big deal in those days. But they kind of shook it off and figured a strategy of bringing more physicians to the community, building a new hospital, and having care close to home. And that's the strategy we work on today. Every minute of the day, we're trying to figure out what can we do to provide first-class care in our community so people don't have to leave it to get care. And we'll talk a little more in detail on that. And so that's what we decided to do. And then at the same time, right around this time here, when we moved to the location we're in right now, Holloman, we've been working on them for a number of years to close their hospital. Because it was in 1991, during Desert Storm and Desert Shield, they stopped doing OB. Well, OB was 95% of their inpatient mission. So they had a inpatient unit 24/7. We were running an emergency room on the base when 90% of the staff live off the base. And they had an OR, which they were doing 2 to 3 surgeries a day. So the thought was, make yourself a super clinic, really focus in on your primary mission, which is primary care, and do everything else at the hospital. And that's what happened. Took 4 goes to get after that, because we were one of the first hospitals in the Department of Defense doing that, and it was called a shared agreement. I was still on active duty in those days, and I was doing similar things in the Northeast, Fort Drum, New York, and other places where the whole idea was, we have resources, we don't have a mechanism to take advantage of them. And that's what we did. So active duty service members after this could practice in our hospital without a New Mexico license. Well, how was that? Well, because they can only see DOD beneficiaries, which doesn't really help call coverage in the emergency room and stuff like that, because you got to see everybody. But it does help the military keep their active duty physicians competent and keep their skills up and all that. So that worked out well. So with that, as we concentrated everything in the hospital here, we could start to grow. And so we moved to that location, and from the day we moved in, why isn't that moving? Let me just see if this will, we'll try that and then see if it unfreezes. We've spent another $170 million making the hospital bigger. And literally from the day we moved in. First thing we did after we built the new hospital, we found out that we were a 100-bed hospital, but double occupancy. And we had a 5-bed ICU in the old hospital, and we said, we have a 5-bed in the new one, which immediately was a bad idea. So they went ahead and built a 12-bed ICU from the, almost from before we even finished, finally all the stuff related to that. And then in 2006, change happened. The orthopedic surgeons, Dr. Dotson and his group left the hospital to have an outpatient surgery center. They're a very nice one there on Indian Wells. And it was kind of the thing to do in those days. But the remaining surgeons said, look, we don't want to leave the hospital, but we don't like hospital ORs. Well, why? Well, because I get everything set up, then I have an emergency C-section, I have an appendectomy we didn't know come in, totally disrupts our flow. And in the days when we were mostly inpatient, it didn't matter. But today, we're 80% outpatient. It matters. It just totally, and in those days, they were independent physicians. So we were hurting them on their ability to make a living. So we built our own. And we did that in 2006. And what we found with that is that before that, we did about 3,500 procedures a year, not counting Dr. Dotson and his group. Now we do close to 7,000. Well, what happened? Well, we added pain, is one thing, but we also are much more efficient. And we're not disrupted, and all those kind of things. Those people run a lean, mean machine over there, and the physicians love working there. So it was really a good move for us. I came in 2008, and right before I came, they were planning a $39 million expansion, and they asked me to go to Nashville to talk to the engineers about it and the architects. And when I came back, I just said, I think we're misguided. We're not doing anything about adding more services and all this construction, not one new piece of revenue to help pay for it. So we changed it and added geropsych. That's I think who's going to the behavioral medicine? Excellent. So we didn't have behavioral medicine prior to then. We had nothing. No outpatient, no inpatient, no psychiatrists, no social workers. But when we did the studies, no surprise to anybody, we had a big, big need in our community, and we needed to take it on. And so that's what we did. And so over the coming years, we kept looking at things, and part of that decision making was we're a hospital with double occupancy. How's that work for privacy? Not real good. How's that work for infection control? Even worse. So our goal was, on the second phase, was to do a $37 million expansion to go to single patient rooms. So this is what we built for that $37 million. And on the bottom floor, we added 35 single patient rooms, which allowed us to go to a single occupancy. We added a new mission, inpatient rehab, a 12-bed unit there, a wonderful service line where typically people come there that have had a stroke, within literally days of having a stroke, or they're very fragile and they've had massive total hips or total knees done, and they come there. And the rule of thumb is you have to be able to undergo intensive therapy 3 hours a day, or the government says you can't be on that unit, which really torques off a lot of the physicians, because we have wonderful PTs there and speech therapists and occupational therapists, but those are the rules. And so if you work on that unit, you're seeing people that couldn't walk, talk, or do anything, and by the time they leave, they can. And about 90% of the time, they get sent back to where they came from, which is good. And we're teaching them how to, first of all, improving it, because they say the first 30 days is critical in getting improvements and how to work through all that, and then teaching them how to live with their situation. And so it's a fantastic service line. At the same time, throughout this period of time, there was something going on that we hadn't experienced before, and one of them was employment of providers. When I came here in 2008, we had 3. Today we have over 70. Well, what happened? No one wants to be independent anymore. It's a pain in the neck. Just as much as we struggle to get paid, they do too, but they don't have the infrastructure that we have. And so a lot of physicians are saying, Jim, I'm retiring unless you employ me. So which would I rather do? Recruit to replace that person, or hire him and know what I'm getting? All day long, I would hire the doc that's been working and committed to this hospital. And so that's what we did. And I'd say of the 70 we have now, probably 15 or prior long-term, been in the community 15, 20 years, in some cases 30 years. And so a smart move to work with folks who we know their quality and what they're doing. So we just started moving through that. Cancer Center was one of them. Dr. Korik, who is a interesting guy, came from left Czechoslovakia at the time of the communist takeover with nothing, came to the United States, was a physician at the time, did a oncology residency at George Washington University, which is an incredible medical center, and came to Alamogordo. And that's where he practiced. And he came to me, he said, Jim, I'm retiring. We got this linear accelerator, because they were an independent group. It costs $3.5 million. We're all retiring in 2 years. There's no way I'm spending $3.5 million to do that. So you guys need to take this over, and I'll stay long enough to transition. That's the kind of guy he was. And that's what we did. And because we thought it was important not to have to travel to Las Cruces to get radiation therapy. You know, typically that procedure takes, by the time you actually have it, 5 minutes after all the setup and everything. But you got to drive an hour and a half or 2 hours to get there by the time you get to the place and all that. And then oncology. You know, who wants to be driving there and get your treatment and come back? You feel lousy. So that's something we need to be doing here. And so we're happy to do that. We expanded behavioral medicine. When we first started, it was a geriatric unit for 55 and older. And then we gradually, as we got better and better staffed, we expanded it to adults. And then this was really cool. In 2015, we partnered with the Hospitals of Providence in El Paso to do a cath lab. It used to be, typically we transfer about 100 to 110 people a month from the emergency room for care somewhere else out of the 2,600 that come there. And so now we transfer about 80. Well, what happened? Cath lab happened. And so my good friend at Mountain View is really upset because he doesn't hear that helicopter flying there. You figure 30 to 35 helicopter trips times $60,000, we save somebody a bunch of money. You figure at least $1 million a month just on transportation costs. Somehow our hospital never benefited from that, from the insurance companies. But the most important thing, our patients benefit from it, because when you're having a heart attack, you want that cath lab right here. You want to be able to get procedures done within minutes and not hours, because every time you delay, you're losing heart tissue, which could simply not ever have you recover to where you were. I know we've saved lives. It's a great crew down there. Dr. Bulware leads that charge for us, and it's been fantastic. We've done over 3,000 casts now since we started this in 2015. Old thinking for years, they used to say you can't have a cath lab without a cardiothoracic surgeon. That might have been the case 30 years ago, but today with all your imaging and high risk, we don't do here. We send them off to El Paso, typically, for that kind of surgery. We expanded behavioral medicine again, because we were finding that we couldn't, we didn't have enough beds. We added urgent care. One of the studies we did, we're required to do a study every 3 years called a community health needs assessment. It has to be a third-party study that says what's the community say we need. They're saying we need an urgent care center. The only place we have to go on Friday, Saturday, or Sunday is the ER. Very expensive. And so we added that, and from the day we put it in, it's been pretty full. And great group of people that work there. Then right now, you see all the construction we're doing on the campus. That's primarily for one reason only. I have no place to put anybody. We have, the clinics we're in are not efficient and they're old. I can't, if I recruited another, and we're typically recruiting a net provider of 4 to 6 a year, I got no place to put them. They don't want to work at my house, I know that. So we're adding a 3-story, 60,000 square foot MOB. We're moving the ambulatory surgery center that was built in 2006 to the bottom of that. So my surgeons will be in that building, my orthopods will be in that building, and the surgery center will be in that building. Kind of like one-stop shopping. That'll be really nice. And so then we'll be able to backfill that and be in a better position to provide appropriate space for our patients and for our physicians. You know, I mentioned about the size of the state. Well, our county, there's 33 counties, and we're the 3rd largest county. And this kind of gives you an idea. There's 66,000 people that live in our county. About 2/3 are right here in Tularosa, Cloudcroft, and us. And I show this, I call this my tyranny of distance slide, because unlike when I lived in Indiana, I was within 20 minutes of 300-bed hospitals on either side of me. First of all, there are not 300 beds in Las Cruces, there are about 180. But the next higher level of care is 80 miles away in Cruces, and then there's a ton of them in El Paso, 90 miles, but depending on where in the city, it could be a lengthy thing. So how do you get there if we can't help them, if they're really beyond our ability? And right now, when we're transferring patients, typically it's for trauma. Multiple trauma that needs a vascular surgeon, needs a team already there, multiple surgeons working on it. We don't have that. And so we'll transfer them typically to the University Hospital in El Paso. Some psych, children for sure, because it's impossible to recruit a child psychiatrist, and we don't have enough volume to run an inpatient unit for that. And so, so they have to be transferred to either Cruces or El Paso, and in some cases to Las Vegas, the state hospital there. And in transferring, there's a couple ways to go. You can go by car if you feel good enough to go, but most times we transfer them by either ambulance or Aerovac. Ambulance, we have 4 in the county that serves this whole county that are running. It used to be 3, they added a 4th one a couple months ago, but you can only have 1 out of the county at any given time. So when my father-in-law had a stroke and he was in our hospital, he waited a day and a half to get transferred. Now, it wasn't an emergency, and so that probably was okay, but he occupied a bed that I could have used for something else. And so we have to think about that. But more importantly, it means we own that patient longer than we normally would. And so we got to be able to take care of them. And so that's why it's good to have experienced providers and nurses. So same thing with the ED. Helicopter doesn't always fly, right? Mostly because of winds. So what happens, we got to keep them there until we can either get an ambulance, which we don't prefer in most cases, or wait for things to settle down to transfer it, or to wait for it to come back because there's just one helicopter. Now sometimes in the region we can get somebody to come by, but it does get to be a logistical issue. But at the end of the day, we got to care for that patient, and we do a great job of sustaining them until we get them to the next higher level of care. So what happens if my MRI goes down? We have 2 MRIs here on this campus. We're fortunate to have that backup, but occasionally the inpatient one might go down. It has a 99.5% uptime, but it's a piece of equipment like anything else. So when it goes down, I call a repairman downtown. No, I don't. They're in Dallas, and they have a 4-hour response time. Same group that goes to El Paso, because it's kind of unique, very limited ability to work with those things. And so occasionally I have to turn to the physician and say, it's going to be a couple hours before that thing gets up and running. What are you going to do? We do have CT. We do have other tools you can use. And typically they do that because they're experienced. Remember I was talking about hiring physicians from in town that have 20 and, well, they've been there, done that. They're used to working and having to work at the full scope of their brain to take care of that patient. But at the end of the day, if it's a patient safety issue, we transfer the patient, which they hate. Boy, that's the last thing you want to do is tell somebody, we got to transfer you because something broke, and so you're going to have to go to El Paso and be 2 hours away from your family. So we don't like doing that, but if that's what we got to do to keep them safe, that's what we'll do. This gives you an idea. You know, I was talking about net revenue. Well, now, back in the mid-'80s, when we were having that conversation with that consulting group and the county, we made $6.5 million revenue. Now it's almost 100, well, it's actually over, this is last year's data. It's over 180 million now, which means we bill out about 800 million. Remember I was talking about that 30 cents on the dollar kind of thing? And so what happened? Well, remember that 70 million that was leaving the county? It ain't leaving the county anymore. So in '99, if you looked at zip codes and you said, anybody with a zip code living in Otero County, what percent of the time are they an inpatient at our hospital? It was 43% of the time. Today, that's over 70%. And so in real dollars, that's why we've grown like that, because we've increased our capacity, added new service line, and added a lot of new providers. During that time frame, before we moved over here, we had 19 specialties, now we have 33. And so we just got to keep working it. ED always kind of amazes me. You know, I was talking about when the town had 3,500 people, now it's more like 33,000. And so everybody in our town gets one visit to the emergency room. No, it's not supposed to work like that. And so I find that that's why we're doubling the size of the emergency room, because it was built for 18,000 visits a year. So we got to figure that out. But I think the biggest issue is we didn't have urgent care, and we didn't have enough primary care. Well, we added urgent care, we've added a lot of primary care providers, and we've kind of slowed that growth rate in the emergency room, because it used to be 3 to 5% increase a year. And so that's lessened a little bit, but we still got some work to do in there on having a broader footprint for primary care. Inpatients have stayed around 4,000. Most hospitals are seeing that drop. Well, the reason it's staying pretty stable is we've added a bunch of new missions in that time frame. You know, behavioral medicine, inpatient rehab, and the like. Lots of ancillaries. We are in the baby business. This number vacillates between about 525 and 575, which is a direct correlation to the active duty side of the house. About 30 to 40% of our babies are from the military, and they've changed their mission 3 times in the time I've been here, and so when that goes, our deliveries go like this, because people are coming and going. And so, but we're definitely in the baby business. Interesting number is this one. So as we've added those 70 providers now, We're up to about this, probably more like 140,000 visits now in 28 clinics. And so if you look at our county, for that matter, we're probably employing about 80% of the providers. In 10 years' time, that'll be 100%. There's a couple that don't want to be employed. I don't want them to be employed. They're happy the way they are. Because you come work for the hospital, you got to follow Joint Commission rules or D&V rules. In a private practice, you have a lot more flexibility because we're inefficient. We bring rules, and we unfortunately have to abide by them. But some of them are meant to be safety issues and things like that. So I don't see that really turning the corner for a while. But what that is meaning, one electronic medical record amongst the providers, with a couple exceptions, that being cardiology and cancer, because they're so specialized. But that said, the vast majority, we can see each other, means we can be better. And so I always say that I think when we look at what we have in specialties, we're in pretty good shape. We'd like to have one or two more of the same specialty in some cases, but what we really need to do now is get better integrated. We have the platform to do it, and that's what we're working on. Lots of surgeries. Remember I was telling you 7,000, that dropped a little bit this past year because of COVID, when we had to be shut down for 2 months, which was interesting. We're a D&V hospital, Det Norske Veritas. That's a group out of Norway. It's important you know this. Why does it matter that you pass this inspection, whether it be Joint Commission, which is the one I grew up with, or D&V? Well, there's a thing called conditions of participation that are issued by CMS, Medicare. And it's a little book about that thick, and it's got all kinds of things. You will do this, you will do this, and you will do this. And if you don't, you're not going to see my patients. And these people do that inspection for them. And if you fail, they say, you can't see Medicare or Medicaid. That's 70% of our business. Do we want to fail? I don't think so. Every hospital in the United States, if you fail this thing, you're in big trouble. Now, it's meant to make sure that we're holding to standards and doing good quality and all that, so it's a good thing. I really like D&V, even though they come every year. Used to be we would about every 3 years because we'd get the full accreditation cycle from Joint Commission. But that meant we had about 2.5 years of not necessarily keeping our eye on the ball, right? Because we're busy and we're always JACO ready, not really, because we're taking on another problem. These guys come every year. And this past year, they came like a week before Christmas. I said, are you kidding me? But a great group, oftentimes the same inspectors, which I really like, because sometimes it's hard to figure out what those rules mean. How do you interpret them? Used to be that if you got a different inspector every year, you got a different interpretation. So this group is very sensitive to that and does what Joint Commission used to do. They make us better. They help us grow and continue to improve. So I think it's a great relationship. Then employee-wise, that's 864 full-time equivalents, which means we have, we combine the PRNs and the part-times and all that to come with up that number. But if you counted bodies, it's more like 1,200. When I moved here, it was more like 500. And why? Because we keep adding all these new missions. And outpatient is a big thing for us. We actually get more revenue from outpatient now than from inpatient because of just the size of the practices and things like that. It's important to know the financial health of the institution, and the bottom line is we're an A-rated hospital. I think of the 44 in New Mexico, there's like 3 of us, and we're one of them. We weren't always that way. We had to work hard, and we want to keep it that way because there's all kinds of good things when you get rated well by Standard & Poor. But this now, I'll point this number out to you. So Michelle, how are you? How much does it cost to run our hospital a day? How much you think? 100,000? Way more than that? 200,000. 300,000. $400,000. It costs us $400,000 to run the hospital. It's a lot of money to run a hospital. So if you multiply 400,000, or you divide 400,000 into the money we have in the bank and in investments, you come up with 310 days. So what that means is that we could run our hospital for 310 days if we were shut down, kind of like what happened in March and April. Or some catastrophe or a tornado or something like that. You want that number to be above 300. As our hospital is getting older, we really want that number to be above 500, because we're going to have to hard to believe, but our hospital's 20 years old now, and come in about 15 years, we're going to have to replace it again. So we got to get ready for that. So we got to keep working on that. But that's a very healthy number. The norm for a rural hospital is about 60 days. So we're doing pretty well here. I talk about how we're an independent hospital, but we're not alone. We love partnerships. The board is absolutely adamant. We get offers to be bought every day. We're not interested, because the second we get purchased, we get cannibalized. Our staffing would go down by 25%, and we would be sending people to El Paso or Las Cruces, depending on which for-profit purchased us. We don't want that. We want care in this community. That's why all of you all got to help us every day to fight this battle. Because independent hospitals, they're not many. They're like 400 in the whole United States. And so that means we really got to be on our game every day to continue to be relevant to our community. And that's what we're working on. And it really starts with you, because you're the one doing the work. So help us with that. Great relationship with the University of New Mexico. Years ago, we implemented a teleneurology capability in the emergency room for stroke patients, for administer of TPA, that clot buster, that if you do it, you get incredibly better recovery. ED docs typically don't like to make that call, because if you make the wrong one, you kill the patient. And so used to be, we use this about 400 times a year. Before, we just shipped them all, 400, off to El Paso. Now, of that 400, a third gets sent home, a third get admitted for observation or a full admission, and a third get sent typically to Sierra Hospital, where they have a neurosurgeon available, because we're worried that you might need to do that. Much better use of resources. Patients like it a lot when you can have that versus being sent to El Paso and discharged after a $50,000 helicopter ride. Didn't endear us to very many people. And so, and it's really a great group of folks. UNM asked us to train their surgical residents, their third-year surgical residents down here, because they don't get exposure to rural medicine. They get exposure to trauma in Albuquerque, but not all the other things that a surgeon's got to do, in particular GI procedures. In a rural setting, a general surgeon, typically 30% of what they do is GI. In Albuquerque, they don't do any GI, because you have GI physicians. And so they got to be trained to be able to do that, and they come here and they love coming here. And plus we have really excellent surgeons, and it's just a great thing. Project Echo is where the physicians, particularly our hospitalists, if they're kind of scratching their head and saying, I want to make sure I'm doing the right thing, or can we manage this, or do we need to send them to El Paso or Albuquerque? Well, let me call somebody and ask. And so they'll call the fellowship subspecialty trained folks at UNM and have that conversation. Docs love it. It really does give them a little sense of comfort. And most of the time it's just confirming what they're already thinking, but it sure is nice to have that, and UNM provides that free. One exciting thing that's going on here is family medicine residency program. We're starting one here at Gerald Champion. Our own residency program in partnership with Memorial out of Las Cruces. They've had a family medicine residency program there for years, and my hardest recruit in everything I do is family medicine. because they're so sought after. And so why not train our own? It's a 3-year program. It started 1 July. We have 3 residents. They're in the inpatient phase 1 in Cruces because we don't have enough pediatrics. So they're going to, for a while, they're going to be down there. We hope in 2 or 3 years we'll take it all over. But in the meantime, they've already started, and come next summer, they'll be here. And a summer after that, they'll be graduating, and we'll have 3 hopefully that'll choose to stay. And they say typically if you train them, you keep 70% of them. We hired them, right? It wasn't like my typical recruitment engagement with a new physician is a day and a half. This is a 3.5-year introduction. If we don't know them by then, we're never going to know them, and we know what standards they got trained to. So it's really awesome. Lots of joint ventures. We like being independent. We can work with a lot of different people, a lot of different hospitals. We just recently purchased a home health and hospice group. I was here in town, and I was approached about 3 years ago to do that. I said no. Well, that's not our business. We're not any good at it. And then we kind of reconsidered because no one was. They were going to totally close, and 50 people were going to lose jobs, and they were they were really good. The management was a little dated, but so we said, okay, well, let's find somebody who does do it for a living and partner with him. So we picked a group out of San Antonio, and in February we took it over. Now the beauty of that is, if you think about it, we have a solid primary care base now, about 70 providers, kind of on the front end of hospitalization. We have a really good hospitalist program and other inpatient rehab and all that. And I think we're pretty solid inpatient. But when we discharge patients, many of them don't follow up with their physician. They don't have a physician. They choose not to have a physician. Well, that's when it helps to have a nurse visiting them at home. And so that's what we're going to do. Continuing to increase our touches on patients to make sure that they're not getting readmitted to the hospital because they didn't do something. So we're pretty excited about that. Lots of provider contracts. Our emergency room and hospitalist program are contracted through Envision out of Dallas. Clinical Colleagues is our anesthesia group. Southwest Heart is Dr. Bulware, who runs our interventional program. When we look at services contracts, because it's so complicated, behavioral medicine is a separately licensed unit, has its own rules. You really need somebody to help you stay on top of it. So we work with a group out of Richmond, Virginia, Diamond Healthcare. I've known them for 20 years. They understand rural medicine. Very, very helpful for us to stay up with all the regulations in that highly regulated field. Same thing with inpatient rehab with Milestone. We do contract out Complete RX, and all of these, when we're working with national firms, it means we track ourselves nationally for performance. And typically, we're doing really well. And that's one thing I like, rather than just saying we're good. You can look at all these hospitals, wound care centers, inpatient rehab units, and we're just as good as anybody from a national perspective. And that's what we like to do. We're 98 beds today. We might be 100 beds tomorrow, but we'll never be 101 beds. Why? Because we get paid differently. So you'll see us periodically adjust those numbers, but this is kind of how it's split up now. So about half our beds are med-surg and OB, ICU included in that. About a third of our beds are general psych. We only run about 24. Why? Trying to recruit psychiatrists and nurses. Always a battle. But hopefully we'll get more stable and be able to use that, because we're still transferring patients out of here. And then, of course, rehab, which I've already talked about. 12-member board, fantastic board. One of the reasons I came here, I knew this hospital because we used to go to a lot of meetings together. And you just don't see a hospital like this in rural America. You do not. And it's thanks to the board. And we got 5 physicians that sit on that board, because quality is a conversation we have every time we meet, and that's their responsibility to keep it in front of the board. Somebody asks you about our mission. It's pretty simple, real simple. We just want to be first choice. We don't want to be the only choice. We want people to choose us, because why would I go anywhere else? And that comes from you guys. Not the facility. It's all people and relationships and first impressions. And every one of you, if you're interactive, you have one chance to make a first impression. And if we mess up on that, then what's that do with the relationships as they continue to go through and get care in a hospital? So all of us can play a role in that. Just help us with that. Physicians can work anywhere. They don't certainly need to work in Alamogordo. And so what's their criteria to work somewhere? Number one, safety, patient safety. If they don't feel their staff are safe, they ain't coming here. Two, efficiency. They like to be efficient. And that's why we put in that ambulatory surgery center, because they want to be busy, and three, they want to be out of a hassle of billing and doing all that kind of stuff that the private practitioners have to deal with. There is a fourth one, which is really number one, right? Happy spouse, happy life. That's one we got to keep working on, because the truth is, if more often than not, it might be something to do with that than the work. And then we want you guys to want to work here. We do a survey every year to ask you to rate us and say, what can we work on next? The truth is, we never have enough money. We never have enough time. But if I understand what the priorities are and what people think, we can make better decisions on what we do. And so help us with that, because you're right there. And we just want to be the best for our community, and you guys, we want you to feel good about working at Gerald Champion, because it certainly is an incredible mission. This is what we want to be. We want to, right now in the southern region, we want to be number one. We're frequently number two, occasionally number one. There's about 130 metrics. And for now, we're just trying to get the region, then move to New Mexico, and then nationally. We're in different stages of that currently, but we still got some work to do there, but we're better than we were. We talk values. That's pretty straightforward. We surveyed the staff years ago and resurveyed them as what's important when you're working with somebody in the hospital. What do you want them to see to emulate? We're hiring you to do a job. We're hiring you to be professional, to learn, to grow with us, and to commit to work with each other. Respectful is important in a very tense environment. It's hard to work in a small hospital. You don't have a lot of backup. And when you have somebody call out sick, which is going to happen, we don't have 4 people standing around to replace them. So we have to figure out how to make that as good as we can as we move through this in a very important mission. Innovative used to be integrity, but the staff changed that. They said, you know, with all the pressures, because they read just like I do, on cutting hospitals, because we're of the $3 trillion bill that happens for healthcare in the United States, we're over half of it. It's a lot easier to go after 4,500 hospitals than it is 980,000 providers. And so we're constantly a target for that, which means we got to always figure out how we can do things more efficiently, and you'll hear that, us talking about that all the time. The last two, pretty straightforward. Dedicated, engaged. If you're going to work here, this is a tough job, and I need you to be dedicated, willing to have selfless service. Every person here is going to have a time when you're going, holy moly, I don't feel good today. I got in an argument with somebody, that kid of mine, I could kick him in the rear end because he's not going to school or doing something. I don't know, you got to leave that behind. You got to come to the hospital and just focus on taking care of patients and help us be in a better place. Engaged, we used to have employee forums, but I do them once a quarter. I haven't done that for a while, where I tell you what's going on. It's 1 hour. We have about 70% attendance because we still got patients to take care of. But come to that. I'll tell you what's going on, and if you got a question to ask, you can ask in those forums. I don't see us, I'm going to have to figure out something different for now. And someday we'll get that restored as things settle down. Employee survey, we just had it. Please participate in it. Our hospital this year was 91% participation. The norm is 70, which tells me I've got owners and not renters. I need you to be owners. We're only going to be good as a team, and how we keep working, understanding that we got to prioritize. And if I don't hear your voice, how do I prioritize effectively? And we step that down to each department. So we'll turn to maternal child, for example, to Lori, and say, okay, what did the staff say? What are your 3 goals for this year to respond to that? And let's work on it and talk about it as the year goes along, and then reload. Sometimes we take on an issue and it didn't work. Well, staff will let us know. And then we try to talk some more and figure out, okay, well, then how are we going to get after it better? So help us with that. And at the end of the day, it's about being pride. It's working at a hospital is an incredible thing. You impact people's lives. And you should take great pride in that you're doing that. You'll hear us talk these pillars of excellence: team, quality, service, finance, growth. If you get these 3 done well, this comes right along. This is the area that we're working on all the time. Team is obvious. You really only succeed in healthcare. I mean, it's very complex. You figure we got 1,200 people now. Communication is everything. I'm trying to make sure we hit it right every time. Job 1 is quality. No one expects to come to a hospital and leave worse. It happens because it depends on where they're at, but most times not. And then service affects quality. A lot of people think this is a gimmick. It is not a gimmick. The reality is, it is a proven fact that better communication, and that's all service is, improves clinical outcomes. If you're sitting in the emergency room and you're not talking to that patient and being engaged with them and helping reduce their anxiety and telling them what's going on, their outcomes are not going to be as good. That's just a proven fact. And so that goes across every chance we get. We got to figure out how to do better with that, and the rest will follow if we stay on top of those first 3 pillars. If somebody asks you what's our mindset and our focus, remember back in the 80s, the consultant said care close to home. It's still the same. No question about it. But if we're going to do it, we got to do it as good as anybody, or even better. I like better. We have people coming from Albuquerque for our behavioral medicine unit. We have people coming to getting wound care from Deming. When we lived in the old hospital, what was our name? It wasn't Gerald Champion Regional Hospital, it was Gerald Champion Memorial Hospital. And so when we moved, we changed our name to Regional because we knew if we want to be at Alamogordo Hospital, we can be 25 beds. We can be 300 staff. And our region is going to end up traveling to Las Cruces and El Paso. We don't want that. And so that's why we changed our name to Regional. We're staying focused on that. And then investing in you guys and in a physical plant. We do a lot of things on investment in that, and tuition assistance, for example. Hospitals are still a place, if you want, you can grow. I mean, I've had cashiers become nurses. It took them about 8 years, but they got it done. And we help with that, and we're happy to help with that. Whoops, I always show this. These are just different programs we have for benefits. I think we have a pretty good vacation program. SwiftMD is kind of cool. That when we had to modify our health plan a few years ago, this is basically urgent care over the phone by board certified emergency room docs, and be sure you sign up. That's for family. That's not just for you. And the only thing you're going to incur is the cost of the medications, not the consultation. We pay for that. And the staff, it's one of the few programs I've put in actually works and seems to work for everybody. So I've really enjoyed that one. Let's see. We do still do merits. We do a 401k. Our program here is if you put in 6%, we match 3.5%, and you should do that. About 90% of our staff participate in this. You know, you're just giving away money if you don't match it. And the truth is, savings starts, the most important thing to have enough money when you retire is to save early and often, as much as you can afford, because in time, that'll pay off for you. Who knows what's going to be with Social Security in another 10, 15 years. So you need to try to max that out where you can, and everybody's a little bit different on that. If you eat in our cafeteria, you get 25% off and all those kind of things. We used to do an annual picnic. We used to have a Christmas party. Hopefully one of these days we'll get back to doing that, because typically we have to do it in the Tay Center. Everything else is too small for us. But we have a lot of fun with that. These are just things we're working on for this year. Our fiscal year starts 1 July. And so those 2 buildings you see at the far end has got all the white paper stuck on it. We're moving HR back on campus. We're opening a conference center because we don't have enough space in the hospital to account for that. That pavilion, we call that the pavilion, we're going to move those guys come March. It took about 14 months to build that. It's moving pretty fast. But we need to move fast. We are going to renovate the cancer center as part of all this effort because, frankly, we need nicer space for our cancer patients. We're going to do that. Lots of national certifications. Besides just D&V or Joint Commission, we like to have other people look at us, challenge us, and show what we're made of from a national standard perspective. I already talked about family medicine. We started telemedicine. We were working on that before COVID. It was kind of timely. So now our clinics have the capability to do virtual visits throughout our 28 clinics. And that's just something we're just starting on. It'll take us a couple years to get in the groove with that. But I'm pretty sure it's going to be the kind of part of our life from here on going forward, which I think is a good thing. You know, if you live in Mayhill and you had surgery and you just got to come in and have your sutures checked, right? Like if you had your gallbladder out or something like that, well, why can't you just do that from home by video? You can. And so saves them a lot of time. So that would be good. Dr. Simmons, one of our long-term independent neurologists, came to work for us this past July. I've been bugging him for a few years. He's a fantastic neurologist. And like most people, because he's been here for 15, 20 years, a third of his practice is primary care, and I don't need a neurologist doing primary care. I need him doing neurology. And so we're going to work on that, and we're thrilled to have him join our team. And then this is just that community health needs assessment every 3 years. That'll be up again. And then we're looking at our total wage and salary. We're always trying to figure out how to build our wage and salary structure, and we got to get professional help with that because that's complicated. But it's time for us to look at that as well. And so here, these are pictures my board chair takes, Norm Arnold, through the community, and it's a kind of a pretty place. If you've not been here before, there's really a lot of things to do normally, a little less so right now, but it's a beautiful place, and make sure you take advantage of it because time will fly while you're here. And so, did anybody have any questions for me? Thank you for joining our team. Be a part of it. Let me hear from you. Take care of my patients.